Okay, so we're going to be discussing glomerulonephritis, but because of the extensive information here, most likely will be divided into lectures. So the initial thing that we should know is to recognize a normal glomerulus. And a few things that we need to pay attention is the cellularity. You see the cellularity is fine. The Bowman space is very well preserved. One thing that also we need to look at is the basement membrane. The best way to know if the basement membrane is normal or if it is thickened is to compare with the basement membrane of the tubules. They usually are about the same thickness, and that gives the pathologist an idea if the basement membrane is normal or if there is some other abnormality.
So we had this guy come in a few days ago, and his kind of like main complaint coming in was just kind of some increasing shortness of breath over the last couple of days, and then this productive cough. So ultimately this guy, he has a past medical history, stage 3 CKD, hypertension. He has like a remote history of Guillain-Barré syndrome in the 70s.
Hypertension is a common finding, oliguria. Sometimes in this patient with acute glomerulonephritis, the urine may turn like dark. It may look a little bit like Coca-Cola, like happens, for example, in the post-streptococcal GA. The urine analysis will be nephritic, so there will be subnephrotic proteinuria, which means usually it's no more than 1 gram or something like that. Again, dysmorphic red blood cell gas, those are going to tell us that there is a glomerulonephritis. The kidney function may be affected, so the BUN, the creatinine, may be elevated. And sometimes it's necessary to also do a kidney biopsy.
So he complained of shortness of breath, coughing, dizziness, and palpitations for about 2 or 3 days. He recently, his cardiologist had recently retired and instructed him that if his heart rate if he were feeling palpitations and his heart rate was about like 130 or more, he needed to come to the ED, so that's why he showed up. So he has this chronic dry cough that became productive of like a yellow phlegm approximately a week ago. And then he also, he hasn't been around anybody that's been sick. He had this worsening shortness of breath for about 2 or 3 days. So apart from that, he hasn't traveled, no sick contacts that he knows of. He hasn't been feverish.
So basically the main thing is he was short of breath, his heart rate high, productive cough.
Yeah.
And then a couple episodes of diarrhea before he came. Okay. Anybody have any questions about his HPI?
So let's start with the vignette and let's see if we can analyze. And what I would like somebody to read it. Maybe we can start here. You want? Go ahead and read.
30-year-old man seen because he noticed dark urine for the past 2 days, swelling of his face and ankles since yesterday. He had an episode of sore throat 10 days ago with fever and cervical lymphadenopathies. Past medical history is unremarkable. BP 170 over 95, temp 98.6. Pulse 84, edema is described. The rest of the examination is normal. Creatinine 1.5, urinalysis, red blood cell cast, 3+ blood, 10-15 leukocytes per high-powered field. Urine protein 1,200 milligrams per gram. C3 low, C4 normal. ASO titer is elevated. What is the most likely diagnosis?
I mean, this is a classic one. I think there is not too much of the discussion here. All the elements are there. This is a patient that has a post-streptococcal GN, in other words, infection-related GN. And you see again how the complement helps. C3 is low and C4 is normal. So immediately you know the diagnosis. The other thing that is very important to remember in the post-streptococcal is that the problem happens, let's say today, the patient has the sore throat. Then you have a period of time to develop the immune complexes. It's going to take 10, 12 days or even more. So that's very important, that sequence, because there are others, like for example, IgA nephropathy, that is called sympharingitis. The patient gets the sore throat and within 24 hours, these people start having usually macroscopic hematuria. Also in the IgA nephropathy, the complement is going to remain normal. So that would be the closest one. Lupus, the patient is lacking everything else for lupus here. A minimal chain disease is a nephrotic syndrome. So this is a patient with an infection-related GN. So that's the explanation. This is a glomerulus in a patient with infection-related GN. You see, it's hypercellular. The arrow is telling you that even all the cells are covering the glomerulus. There is no bounding space there. So it's very characteristic of the infection-related that is hypercellular. And when you do an electron microscopy, you're going to find subepithelial deposits. So you see the basement membrane, and then outside, at the level of the podocytes, are the deposits. So that's very characteristic also of the infection-related GN. So just a little summary of the post-streptococcal. Immune complexes in the subepithelial area. Symptoms start 10 to 12 days after the infection. Mild edema, hypertension, dark urine, oliguria, low C3, order ASO titer and anti-DNAs will be elevated. Hematuria usually resolve in 3 months and the proteinuria in 6 months. The prognosis is good. Most of these patients, they resolve. Infection-related glomerulonephritis due to staph, 2 things. The infection and the glomerulonephritis happen at the same time, and not necessarily all the times with the staphylococcal type, the complement will be low. Maybe low, but maybe normal. So those are 2 things to remember here.
Heart rate 122, respiratory rate 28, temperature 97.9.
I can write that fast. 122.
Respiratory rate was 28. He was afebrile and he was setting 93%
for America.
Physical exam.
Physical exam was generally unremarkable. He was a little bit tachypnic, as evidenced by his respiratory rate right there. He was just kind of having some increased work of breathing, maybe some mild use of accessory muscles. Other than that, a little bit of a wheezing. He had a positive fluid wave. He did have 2+ pitting edema when he came in.
Bilateral.
Bilaterally.
And his heart
He
rate
would
was
email.
it was truly regular?
It was irregularly irregular.
So what could some of these waves kind of be? Here. Flutter? Yeah, this is atrial flutter, right? Yeah, so you have that 120. So some of that, just a little trick, when you see these rates of 120 and like 120 and 125 and 150 and 155, and it's regular, flutter should kind of jump in your head. Okay. All right. So now let's run a differential diagnosis before we go ahead and decide to see what we think is causing this patient's symptoms and how we're going to manage it. So I'm going to start in the back and work our way this way. The interns and then we'll go to secondaries. On your differential diagnosis, what do you think is causing this guy's symptoms?
Acute decompensation.
Okay, acute decompensation. So just so you know, okay. I mean, why do you say that? I guess the BNP is high. The X-ray we talked about. Okay, but let me tell you one thing that we didn't necessarily Monica asked. He had an echo done when?
In May.
So let me just give that to you because we have an echo in May. So let me just give you the full echo.
So you see a red blood cell cast. Again here, the patient had a sore throat, and 24 hours later, the patient started having macroscopic hematuria. So this is the classic presentation of the patient with IgA nephropathy. IgA nephropathy also has been associated after extreme exercise. So patient doing very, very heavy exercise sometimes may have precipitated IgA. These are people that have a tendency to recur over the years. And the prognosis most of the time is not bad. This patient with IgA nephropathy, the cells are galactose deficient. And sometimes may be also associated with other conditions that have IgA in the background. For example, a patient with celiac disease may sometimes have IgA nephropathy. And also Henoch line may be associated with IgA nephropathy. As I said, this sympharyngitic, complements remain normal, These people, what they usually have is episode of macroscopic hematuria. So that's the explanation there. It is the most common cause of chronic glomerulonephritis worldwide. So it's the most common cause of glomerular hematuria all over the world. Glomerular, not hematuria, just glomerular. It's more common in men, second and third decade. It may be associated with Henoch lung, IBD, and celiac disease. Genetic predisposition with IgA molecules, galactose deficient. Immune complex with IgA deposits in the mesangium. Even when there are immune complexes, the C3 remains normal and the C4 too, because it happens a little bit more slowly, so there is time to compensate producing the complement. So the complement will be normal in these people. So asymptomatic microscopic hematuria and gross hematuria following an URI, sympharingitic, 24 to 40 hours later. Kidney biopsy, it will show mesangial expansion. I'll show you an example. Treatment is really to treat mostly the proteinuria, ACE inhibitors, ARBs. And over the years, they have recommended to use fish oil and statins, even when it's a little questionable if they really do anything.
I mean, is that on your differential for another reason, or?
Yeah, well, he's short of breath, his tachypneic is hypoxic.
Sure, there's nothing else? Is that also a productive call?
Pneumonia or some kind of.
Okay, so sepsis infection, because again, your future field read that as actually they suggested that there is pneumonia. So that was we rely on you guys. Usually you say pneumonia, we go pneumonia. So you're telling us pneumonia. You want to put that up there?
Yeah.
You're going to people.
Yeah.
So so pneumonia, sepsis, okay, infection, we'll put that infectious stuff. Tachycardia, he meets SIRS, right? Like he has this. He certainly meets SIRS, so okay. What the most common that he has, most can kill him, but this is why we go through every admission, go through this exercise. This is how you learn, and I think that's a good differential, Cheyenne, because maybe the X-ray, you might think of something else that might show you, it might guide another test and to consider. So maybe if you think it's less, you don't have to do that other test that you do to consider this. So, okay, amiodarone toxicity, good. Anybody have any other differential?
Differential diagnosis. Pretty odd, but COVID with post-COVID myocarditis.
You can blame, like I always say, you can blame COVID for everything. COVID's going to try to take credit. So, sure, I guess I could never not, give COVID a shot. So let's go to management. So let's see. So now we have this differential. So now in your brain you're thinking, what's the highest? What's the most likely to kill him? How am I going to order testing to figure out what this guy may or may not have, or is the diagnosis already made for you possibly? I don't know. You can order an echo, certainly. You have the echo I showed you from May. But remember, this is legit, this is real life. This guy comes in on Saturday, there's no echo techs on Saturday. Sunday, you can get echoes done sporadically. We've all seen how echoes get done Saturday, plus or minus a read. You probably really have to chase it, to get it done. You have to chase a cardiopulmonary. So it's okay if that's what you want to order. You want to try your bedside ultrasound. Is that what you want? And are you calling cardiology to do it now, or are you just ordering it? And I'm cool waiting until Monday to get my result. So you want to use it. You want to get a CT to help you differentiate this, and possibly this. Any other interns want to treat with antibiotics? You guys want? No antibiotics? Sterling, no antibiotics? No? Seniors, how do you guys feel? MRSA, you want a MRSA swab?
Actually, I don't even want to start right. Don't even.
Okay. So you want sputum cultures, you want other data, you want more data to help you determine if it's an infection or not. Okay.
Everybody picked up on Britt's concern about azithromycin. His QT was long.
All right, so everyone's cool, just leaving the next day. You just want to repeat labs basically and see how he responds? What's causing it? You thought this was sinus tachycardia. What's causing? Okay, maybe you're going after this more. If you don't think it's sinus rhythm, okay, we're here, and what's causing this here, right? Or, is this causing this? Are these linked here? Okay, so what do you think? You see this EKG, he's been tachy at 120s the whole time. He's on his amiodarone, right? Okay, he's on amiodarone. Amiodarone, you should, if you have an 80-year-old down on amiodarone, what should the rhythm be? I mean, you can use amiodarone for rate control, but if you're on amiodarone at 80, I hope you're in sinus rhythm. Like, that's not it's amiodarone's last line, right? This guy's had PVI, this guy's had cardioversion, and this guy's on amiodarone. So you would hope he's holding sinus rhythm, and Again, I'm not so sure that this is a sinus rhythm. I think this is also, these are flutter waves. So, what do you guys want to do? So again, I think this is a cardiology case. This is a complicated EP case because, again, he's had PVI, cardioversion. PVI in the last year, right? It was a year, within a year he had PVI. Been on amiodarone, cardioverted, lost to follow because his EP was Dr. Babawe who left. So he hasn't gotten back in. So for our purposes, why do you need an echo? The guy's on amiodarone in atrial flutter, sitting there at 120. So I think you can put him on IV amiodarone in this case. I mean, he's got the Washington device. You can probably try that, but I would get the experts involved. Like this is kind of an EP consult here. Again,
the echo's probably already done, and the fellow can read his own echo.
If you got the echo done, possibly, yeah. Let's say I don't think they were able to do it. I don't think they even got the echo done. So they didn't tell me they didn't do it. I keep on looking. But I think that you have something like this, the arrhythmia. This guy's probably not tolerating his arrhythmia. Who knows how long he's been in it for too? Because he's been complaining for some time. Maybe he's been in it for a couple months. He's at the point where he needs his AV node, where he needs to ablate his AV node. Now although sometimes atrial flutter is different pathways, and I don't know if I think he had fib flutter though in the past. I think he has both. So sometimes flutter is a different pathway, right? Yeah, but I think at this point it's time for the AV node ablation probably because he's failed amiodarone, PVI, all this stuff. The only thing you can do is ablate his AV nodes. But this is why this is great follow for Radical, future cardiology, likes cardiology. And you guys should recruit these patients. This is a great patient to follow into a resident clinic and have continuity with over the next 2 years. He wants to follow with us, so this is great continuity of care and outpatient management to see what we do.